Hello, everyone. Thank you guys so much for tuning in. This is actually part 2, or the second video, however you want to call it, of my Nclex tutoring. The first video is actually up, so if you want to tune to the first video before coming to the second video, the first video is available. This is just going to piggyback off of the 5 questions that I spoke about in the first video. Like I said before, as far as the Nclex goes, they're not going to give you separate systems at a time. All the questions are pretty much going to be thrown at you. So why not present the questions to you that way? So I'm just going to pretty much throw different questions at you, and we're going to break those questions down. For those of you who are new to my channel, my name is Frances George, also known as Dr. Nurse Tutor. I am a 15-year experienced registered nurse at the bedside. I have 6 years experience as a family nurse practitioner. I have a postmaster's in higher education with online teaching and learning, and I also have a PhD in nursing education. I have been tutoring students, preparing them for their Nclex as well as the AANP certification exam, because that is where my specialties lie. So on my channel, I will be prepping students and tutoring students, getting them prepared for the Nclex, and I also will have sections where I will delve into preparation for AANP certifications. So if I have any master's level students that are available, please either drop a comment down below or just wait, and I will definitely have sections where I dedicate my tutoring to master's level students. Now on my video platform, I will have anywhere between 5 to 7 questions. I noticed since the first video that I made, 5 questions is maybe where I kind of need to stick at, because it takes me about 30 minutes to go through 5 questions completely, because not only do I discuss the question as well as the answer, I break down each question to give you the rationale as to why the answer is the answer. That's what Dr. Nurse Tutor is all about. I break down and delve into the questions, so not only do you get the answer right, you know why, and you understand the rationale behind why the answers are correct and why the options that are incorrect are incorrect. So not only are you going to be able to pull the correct answer out of the questions, you're going to be a great critical thinker. That's the biggest thing that I want you to take away from my tutoring sessions. Not only are you going to pass your Nclex or your AANP certification, but I want to make sure that you're going to make a good nurse and a good advanced practice nurse based off the information and the knowledge that you gain from my tutoring sessions. Now, if you would like more time with me and enjoy the information that I'm giving you from these videos, and you want to have one-on-one sessions with me, that is definitely an option. I will have my contact information down in the link below. I'll have my email address. Just shoot me an email and we can discuss availability times so that we can get together and we can do one-on-one tutoring sessions together. Also, if you like what you see on my video, please like, comment, and subscribe below so I can bring more material to you and hopefully start to make some things make sense with studying for this Nclex, because I know it can be grueling. Trust me, I have taken the Nclex. I took a med-surg certification exam as well as my AANP. And once I understood the material and I was able to grasp the content as a visual as well as an auditory learner, there was really nothing that could be presented to me that I wasn't able to break down as far as the systems, how the systems work, and how disease processes work. So I hope the knowledge that I'm giving you is going to allow you to understand the information as well as how to critically think to detect the correct answers in the questions. So with that being said, I'm going to start with the first question. And the first question is: the administration of an intramuscular injection to a neonate should be given in the. So basically, the question is asking, you have a neonate, which is a child, a baby. They want to know where you would administer an intramuscular injection. So intramuscular is an IM injection that is going into the muscle. So injections are usually intramuscular, subcutaneous, or you would put it through an intravenous, which would be an IV. So subcutaneous is underneath the skin. Intramuscular is going into the muscle, and intravenous is going into an IV. So in this case, it's an intramuscular injection that is going into a neonate, which is a baby or a child. Where would you place that injection? And the options that they have is the gluteus maximus muscle, the vastus lateralis muscle, the deltoid muscle, or the sternocleidomastoid muscle. Now, I want to look at these options that they have here, and I want to break them down to try to figure out what the right answer would be. Now, I'm going to start from the bottom and work my way up to see what I want to eliminate, because like before I said in the last video, usually there are going to be two options that are completely off the wall and don't need to be there, and there would not be injection sites. I'm going to start with D, which says the sternocleidomastoid muscle. The sternocleidomastoid muscle is not an area that we would give an injection. We're not giving IM injections in the sternocleidomastoid muscle. Then there's the deltoid. The deltoid is a muscle, that's C. The deltoid is a muscle that we give injections in. The vastus lateralis is also an injection site that we give injections in. Then you have the gluteus maximus muscle. Now, I know about the vastus lateralis, that's the thigh muscle. I know about the deltoid muscle. We already said the sternocleidomastoid is not a muscle that we give IM injections in, so we threw that away. Now, the gluteus maximus muscle, we usually don't give injections in the gluteus maximus. That is the actual butt muscle itself. We usually don't give injections in the gluteus maximus. We usually give injections. What I'm actually going to talk about that later because that's another question, but that's the actual butt muscle itself. So if you think about the hip area and you think about the actual butt muscle, where the actual tissue is, where the butt is, that's not really an area. We're not going to go and give a patient an injection in their butt. It's just not a muscle that we put injections in. So usually the deltoid muscle and the vastus lateralis, they make more sense to me because I know for a fact that injections go in those two muscles. Now, I have to decipher whether or not if it's the vastus lateralis or if it's the deltoid muscle. Now, when you're thinking about a neonate, you're thinking about a baby, the option would be the thigh, the vastus lateralis. And the reason for that is because the deltoid muscle of a baby has not developed yet. So you cannot go ahead and put an injection in a baby's deltoid muscle because it hasn't developed. If it was an adult, then maybe we could put the injection in the deltoid muscle, but not for a neonate. Neonates are usually going to get their IM injections in the vastus lateralis. So anytime you see a baby or some sort of a pediatric patient, just know that their injections usually go in the vastus lateralis until the deltoid muscle has fully developed. So just understanding that the sternocleidomastoid is not where you put injections, and that the gluteus maximus, they're trying to confuse you because you're not putting it into the butt tissue. It's not going in there. So it's either the vastus lateralis or it's the deltoid. And like I said, the deltoid is for adults and not for kids, not for neonates. So it would be the vastus lateralis. All right, so the next question is, which site or technique would you expect to administer ferrous sulfate as an injection? So what site or technique would you expect to administer ferrous sulfate? So they want to know that you know where to put ferrous sulfate, which is iron. How would you administer that as an injection? The first option, A, says a subcutaneous injection site. The second option, B, says the PQRST technique. The third, which is C, says the Z-track technique. And the fourth, which is D, says the sublingual site. We just have to break this down and we have to understand what the mode of transmission is for all of these options that are presented to us. So I'm going to start with D because I like to omit the ones that I know are completely far-fetched. So we're going to start from the bottom, the same way that I did with the previous question, because like I said, I like to point out the options that are completely off the wall before I move on. So the first one says a sublingual site. So if you don't know what sublingual site is, we're going to have to talk about that so that you understand why this is an off-the-wall option. Sublingual means under the tongue. And then it says a sublingual site. We're not putting an IM injection underneath someone's tongue. The only thing that goes under your tongue is a tablet. So if we're administering ferrous sulfate as a site or a technique, which is asking us about an injection, you're not sticking ferrous sulfate under your tongue. There isn't even a ferrous sulfate tablet to stick under your tongue. You take it as a tablet and you swallow it with water. So that is not the option. The Z-Track technique is basically a technique that you would put an injection in to avoid the solution of the injection from spreading into other tissues. And why you would do a Z-Track technique is to keep that medication from spreading into the tissues and causing staining and other unsightly things that an injection that would be of a dark solution that could stain. You don't want it to stain the patient's skin. So you would do the Z-Track technique just to pull the skin back, hold it taut, do the IM injection, and keep the medication from dispersing and causing staining. The other one is the PQRST technique, and PQRST technique is not for injection sites. PQRST technique is actually a technique that is used to describe the quality of someone's pain. P is provoked, what causes or increases the pain. Q is the quality of the pain. Is it throbbing? Is it dull? Is it burning? Is it stabbing? R is the region. Where on the body does the pain occur or originate from? And S is severity, from rating your pain from 1 to 10. So even though that is definitely not the option, that's something good to know what PQRST is. So we automatically know PQRST and sublingual are not the options that we're looking for. So we could throw B and we could throw D out. Now we have the Z-Track technique, and then I'm going to look at A. A says a subcutaneous injection site. Now subcutaneous means under the skin. When you're giving ferrous sulfate, that is an IM injection. A Z-Track technique is done with an IM injection. So A is not the answer because subcutaneous goes under the skin. Ferrous sulfate injection is an IM injection. So it's safe to say that A, B, and D are not the options. And Z-Track would be the technique that you would want to do because you don't want that fluid to leak out of the area where the injection was made and to stain the skin or to irritate the area. So you would want to do a Z-Track technique whenever you were giving a ferrous sulfate injection to a patient. Now the next question, you are precepting a new graduate nurse who will be administering an intramuscular injection to an adult client. The new graduate identifies the gluteus maximus muscle by palpating it. See, we're talking about gluteus maximus again. So you're precepting a new graduate nurse who will be administering an intramuscular injection to an adult client. The new graduate identifies the gluteus maximus muscle by palpating it. What would you do? So you are an experienced nurse who are precepting a new grad who needs to give an IM injection, but this new grad palpates the gluteus maximus muscle. What would you as the experienced nurse do? A, would you allow the nurse to administer the injection? B, would you ask the nurse to use the vastus lateralis muscle instead? Remember, that's the thigh. C, would you ask the nurse to verify the doctor's orders again? Or D, would you stop the nurse from administering the injection? Remember when I said the gluteus maximus is that butt muscle, that butt tissue. We don't put injections in the gluteus maximus, okay? It's going in the vastus lateralis. It's going in the deltoid. It's going in the ventrogluteal muscle of the hip, or is going in the dorsogluteal muscle of the buttocks. Those are the only 4 places: deltoid, vastus lateralis, ventrogluteal muscle of the hip, and the dorsogluteus muscle of the buttocks. So the options are, will you allow the nurse to administer the injection into the gluteus maximus? No, because it either is going into the hip or it's going into the dorsogluteal muscle. So no. Are you going to ask the nurse to use the vastus lateralis muscle instead? There's no need to, because we only put that in neonates and children, like I stated above. The vastus lateralis is for kids. You can put it in the deltoid, and you can put it in the hip, or you can put it in the buttock muscle, but not the gluteus maximus. Are you going to stop the nurse from administering the injection? Yeah, you better believe it. Injections do not go into the gluteus maximus. If you want to put it in that region, you're looking for the ventral gluteal muscle of the hip or the dorsal gluteal muscle of the buttocks. So those are the only options that we have for adults: deltoid, ventral gluteal, or dorsal gluteal. Vastus lateralis, we usually do that for neonates. Yes, you can do it in the vastus lateralis of adults, but the options, the areas that we usually go for are the three that I stated previously: the deltoid, ventral gluteal, and the dorsal gluteal. Now, the next question is, which of the following clients is at greatest risk for extravasation? I struggle with words too. Which of the following clients is at greatest risk for extravasation? Now, we need to know what extravasation is before we can even say which client would be at risk for it. So extravasation refers to leakage of injected drugs from blood vessels, causing damage to surrounding tissues. So why is that a problem? So common symptoms and signs of extravasation includes pain, stinging, burning sensations, and edema around the intravenous IV site. So what does that mean? What drugs are usually culprits for causing extravasation? Your chemotherapy drugs. Your chemotherapy drugs can definitely leak into surrounding tissue. If you had an IV or something that infiltrated maybe, and the fluid ended up leaking around the surrounding tissue, it can cause pain, stinging, and burning sensations, and it can also cause necrosis of the tissue. So a lot of times you will see patients will have a port. If they're receiving chemotherapy drugs, a lot of times your patients will have a port to avoid these situations, but it is still good to know that chemotherapy medications can cause extravasation. So let's look at the options that we have here. A is a client. So which of the following clients is at greatest risk of extravasation? So A is a client who has heart failure who is receiving lactated ringers. B is a patient with cancer who is receiving bendamustine. C is a client who is receiving potassium supplementation intravenously. And D is a client who is receiving total parenteral nutrition, which is TPN. So, of course, I gave you the answer by letting you know what extravasation is and who is at risk for it. Those are your cancer patients who are receiving cancer drugs. So the patient who was on bendamustine is at the greatest risk for extravasation. And the reason is because when an irritating vesicant goes in and infiltrates the tissues, it can cause the pain, it can cause the pain, the stinging, the burning sensations, and the edema around. In worst case scenario, it can also lead to necrosis of the affected limb. So it's very important that those patients get a port placed as opposed to putting chemotherapy drugs through an IV. So the other options, lactated ringers are not going to cause extravasation. It may cause some infiltration of the fluid around the tissues. And the other one is potassium. Potassium can sting. There is evidence that potassium can sting, but it's not going to cause extravasation. And then TPN, a patient who is receiving TPN may be at an increased risk of having an infection, but not so much extravasation, because patients who have TPNs, they have like PICC lines that are actually tunneled lines, and those lines can tend to get infected as opposed to causing irritation or tissue necrosis. So you will see that more so with patients who are receiving IV chemotherapy drugs as opposed to any of the other options. So just know that if you see a chemotherapy drug you'll know that would be. And even if you don't know, like say the option doesn't say a patient who has cancer, because that would be another way that they will throw it up to trip you. They may not even tell you that the patient has cancer. They just may say the medication name. Even if you don't know the name of the medication, you know that lactated ringers is an IV fluid. The most that lactated ringers are going to do is infiltrate if the vein is not patent, and the IV causes leakage. Just know that it's going to cause infiltration, which the surrounding tissue will be edematous, and the skin will be cool to the touch. And know that potassium can be given through the IV, but potassium will cause irritation, but it won't cause tissue necrosis. And even TPN is not something that is going to cause tissue necrosis or irritation. So even if you don't know what bendamustine is, if they were to tell you a different chemotherapy drug, just know which medications can go through an IV. We know for a fact that patients are going to get lactated ringers. We know for a fact that a patient's going to get potassium through their IV. And we know for a fact that patients can get TPN through a PICC line, and it's not going to cause necrosis of the tissues. So if you're able to exclude those options, at least you know you're left with something. Even if you don't know the name of the medication or what it's for, you know what to omit because you are familiar with the medications that will not cause the extravasation. So the biggest thing is just knowing what that word means. And like I said, it's an irritant that can lead to pain, edema, and at worst, tissue necrosis. All right. Okay, so we're going to do the last question. And the last question says, select the complication of intravenous therapy that is accurately paired with one of its interventions. Sounds like a whole bunch of words, but we'll break this question down. The question wants you to select a complication of an IV therapy. So which one of these options, these options are going to show you complications of IV therapy, but they want you to give them the correct complication to an IV therapy. So select the complication of IV therapy that is actually paired with its intervention. So give me a complication that would happen with IV therapy and tell me which one is paired with the correct intervention to help relieve the symptoms of the complication. So the first one is infection. They want you to lower the limb to promote circulation. The second one is infiltration, application of cold to the site. The third one is extravasation, which we spoke about before, the aspiration of contents, including blood from the IV cannula. So pulling the actual contents out of the vein along with any blood. Then the last one is hematoma and the administration of dextrazoxane. So we know that an infection is heat, swelling, maybe some purulent drainage, some pus coming out of the infection, out of the IV site to let us know there is an infection. Infiltration means that the IV fluid gets into the surrounding tissue. Extravasation, which we heard before, is the irritation, the pain, the swelling, and possible necrosis of the surrounding tissue. And a hematoma is a clot. All right. So infection, it says lower the limb to promote circulation. Now I know with infections, you need to elevate the limb to help to bring down the swelling and the inflammation. You're probably going to put a warm compress on it to rid the tissues of the fluid that was circulating. And then you're going to later want to put a cold compress on there to help to bring down some of that inflammation and help with the infection. So lowering the limb, the first thing about lowering the limb doesn't make sense to me, because usually when someone has an infection, you want to raise the arm as opposed to lowering the limb. So I don't think lowering the limb would be a good option. The next one, which is infiltration, the IV fluids has escaped and gone into the surrounding tissue. Usually when IV fluids finds its way and infiltrates surrounding tissue, that area is going to be swollen, but it's going to be cool to the touch. So application of a cold compress to something that's already cold doesn't really make sense to me. So I don't think the infiltration pairs with application of cold to the site. Infection maybe, but not infiltration of cold to the site. So that doesn't really match up. Now, extravasation, aspiration of the contents, including blood from the IV cannula. We can come back to that. And then hematoma, which is a blood clot, administration of dextrazonzane. Now, dextrazonzane sounds like that'll work to give for an infection, not a hematoma. Because if someone has a clot, you would want to give some sort of a blood thinner for a clot, not for a hematoma. So I don't think this dextrazonzane would be a good option for a hematoma, because you would want to give some sort of a blood thinner. And I know that this medication is not a blood thinner. Even if you don't know what the medication is, you know it's not a blood thinner. Infiltration, I'm not putting cold on cold, because that's not going to do anything for the coolness, though it is edematous due to the infiltration of the fluid into the tissues. I'm not going to put cold on cold. And infection, I'm not going to lower the limb, I'm going to elevate the limb. So the only thing that makes sense with the extravasation is to aspirate the contents, including blood from the IV cannula. Because even if you don't know that you're supposed to do that, which you are supposed to do that, if the chemotherapy medication was to get into the surrounding tissue, to avoid tissue necrosis, you want to aspirate the contents out of the IV cannula, along the fluid as well as the blood that has mixed with that chemo medication, to try to decrease your chances of the surrounding tissue becoming necrotic. Even if you don't know that, you at least know, or I at least want you to know, that with an infection, you're not going to lower your limb, you're going to elevate your limb. With infiltration, it's already cool, so you're not going to put cool on cool. Doesn't make any sense. So you would be left with the extravasation and the hematoma. The one thing I want you to know is a hematoma is a clot. And if the medication, you're not familiar with it being a blood thinner, chances of that is that it's wrong, that it's not the dextrazonzane, because there is no blood thinner by that name. So that wouldn't be the option. The best option would be, and really I would want you to remember that I told you extravasation is the irritating and pain caused by infiltration of an irritant, a chemotherapy drug. And the biggest thing you want to do is take that out to try to avoid necrosis of those tissues. So that's the best way. The hematoma, this medication is not a blood thinner. So, and an infection and infiltration, we would just throw that out and we'd be left with those two options. But the best way to decipher between the two is, of course, knowing that extravasation is the irritation of a chemotherapy drug. And this medication is not for hematomas. So the answer would be C, the extravasation, aspirating the contents out of the IV cannula to help to decrease that patient's chances of having tissue necrosis. All right, so I am going to stop there. We've gone over these 5 questions, and we have just critically thought out what the rationale of the best right answer would be with answering these questions. Like I said before, there's always going to be 2 answers that do not belong, and you can omit them. And even if you can't, if you don't know what the answer are, the process of elimination, either 2 answers are going to sound identical. So you want to pay attention to that. And you're going to be left with 2, and then you can kind of decipher, rationally think as to how you're going to omit one of the options. Like today, when we talked about intramuscular injection sites, know the difference between children and adults. When you're dealing with peds, very young neonate babies, they're going to be the vastus lateralis. There's no way around it, though. That's where their injection sites are, because their deltoids are not fully formed. When it's adults, you know, you're going to do the deltoid. You can also do the vastus lateralis, but we don't really go in that area. The other areas that we go into are the ventrogluteal and the dorsogluteal. Those are the three areas. We do not put injections into the gluteus maximus. That is the actual buttock muscle, so we're not going to do that. Any medications that are going to stain tissue when you give it as an IM injection, you want to do the Z-track. You want to hold that skin back and taut, and then you want to inject the medication, the IM injection in, so that that tissue does not disperse and cause irritation or staining of the tissues. You want to make sure that the areas that you are injecting an IM injection in is the correct area. You also want to make sure that you know what happens when IVs are infiltrated. And you also want to know, which we are going to talk about as well, the different medications and what kind of administration these medicines are going to go into. We talked a little bit about chemotherapy drugs and what they do when you receive those medications through an IV. So there are other methods as to how IV medications are administered that would avoid any sort of tissue necrosis due to infiltration, because that is very important. You have PICC lines, you have midlines, you have IVs, you have tunneled, and you have non-tunneled catheters, which we are going to talk about when I get into those questions. And that's how you'll understand which medication requires these kind of lines. Well, like I said, the IV line, the PICC line, the midline, things of that nature. Some lines are long-term, some lines are short-term. Of course, we know IVs have to be changed every couple of days, and you'll know what medications have to go through what lines. So those are some things that we are going to continue to look into, so you know how to pull those answers. Not only are you going to know how to get those answers on the Nclex, when you see them in practice, you'll say, I remember that. I remember talking about that. And I remember that certain medications have to go into certain lines. Okay, so we're going to stop there. And I should be back in a couple of days with a new set of questions. Like I stated before, if you would like to do one-on-one tutoring with me, you want to spend a little bit more time with me, go over these questions, break these questions down, critically thinking and rationalizing the answers. I do order private tutoring. I do offer private tutoring sessions. You can just send me a message at my email, drnursetutor@gmail.com. If you like what you see and you would like to see more videos, please remember to like, subscribe, and comment to my videos, and I will definitely bring more videos your way. I'm going to do a couple more Nclex videos just so that I can have a few out there that you guys can use as a reference, and then I will let you know when I start with the AANP reviews. If you miss my review, of course, it will be up, and I'll have it labeled which are Nclex reviews and which are AANP reviews. So if I have my master level students who are getting prepared for their AANP certification exam that want to refer to some of my videos just to kind of compare and contrast the way that you're studying, or if you want to do one-on-one tutoring with me, that is an option as well. So be on the lookout for that, and I will have another video up for you in a few days. Just refer to the last two that I have just to kind of give yourself an idea of what my teaching style is and what my teaching strategies are. All right, so thank you guys for watching, and I will see you in a couple of days. Bye.